поширюється вже більш ніж на 75 країн світу. Комерційний оборот Thea становить більш ніж 865 мільйонів євро. Компанія Thea має далекий горизонт стратегічного бачення. Для неї властиве швидке реагування та надійні системи незалежних лабораторій, що займаються виключно вивченням питань офтальмології. Засновники та директори компанії Анрі та Жан-Фредерік Шебре належать до генерації засновників цієї галузі. Thea щільно пов'язана із десятками тисяч спеціалістів-офтальмологів з різних країн, які довіряють нам та яких ми підтримуємо протягом довгого часу, особливо в сферах удосконалення та обміну знаннями. Thea має значний експертний досвід у багатьох галузях, а саме в розробці інноваційних продуктів різних класів, а також досягає успіхів у лікуванні глаукоми, алергії, інфекційних уражень, запалення, хвороби сухого ока. За допомогою Thea було створено нові концепції та нові ринки для продуктів, що не містять консервантів, продуктів для підтримки зору, для гігієни повік, антибіотиків для внутрішньокамерного введення та мідріатиків. Основою вибору найкращих виробників для кожної фармацевтичної форми є зберігання компанією певних стратегічних технологій. Маркетингові технології компанії створено в комбінації з однією з найбільших систем медичних та фармацевтичних контактів у сфері офтальмології. Відділ розробки має визнаний експертний досвід у створенні фармацевтичних форм, розробці продуктів та проведенні як доклінічних, так і клінічних досліджень, а також у сферах реєстрації продуктів та виводу їх на ринок. Thea Open Innovation – споріднена організація компанії Thea, що займається створенням партнерств та підтриманням стартапів, співпрацює з компаніями з розробки медичних та біологічних технологій та з університетами з різних країн світу для створення інноваційних технологій та методів лікування майбутнього. Thea – унікальний партнер у сфері офтальмології.
У світі, де науковий прогрес змінює наші можливості кожного дня, компанія Thea допомагає спеціалістам-офтальмологам, як тим, що тільки починають навчання, так і досвідченим фахівцям, що потребують регулярних тренувань для підтримання професійних навичок. Thea супроводжує спеціалістів-офтальмологів до їх майбутнього за допомогою Академії Thea, що централізує різноманітні активності, присвячені молодим фахівцям. Для підтримки ініціатив, що їх було створено молодими спеціалістами задля молодих спеціалістах, у рамках конференцій EMYO та окремих сесій, що проводилися під час конгресів за участі ведучих офтальмологічних спілок. Для хірургів, що тільки починають практику, чи тих, що хочуть вдосконалити свою техніку, є можливість працювати на симуляторах Dry Lab та Wet Lab або на хірургічних симуляторах. Ми запрошуємо резидентів та лідерів клінічної галузі для участі у Trophy, нашому міжнародному змаганню із презентацією клінічних випадків, що надає лауреатам можливість презентувати свій клінічний досвід у рамках відомих конгресів. Більш ніж 1000 учасників вже спробували свою вдачу. Також ми надаємо інституційну допомогу Європейському комітету з офтальмології, що надає молодим практикам можливість працювати у Європі. Динаміка обміну знаннями та їх розповсюдження не обмежується колом молодих спеціалістів, але стосується усіх практикуючих фахівців, як тих, що тільки починають працювати, так і визнаних спеціалістів. Глобальна ініціатива безперервного навчання відображується у проведенні численних заходів, що їх присвячено різним видам патології. Thea підтримує престижні заходи, наприклад, міжнародний симпозіум з глаукоми Мурфілд, що надає унікальну та рідкісну можливість вдосконалення, тому що цей симпозіум відвідують найкращі фахівці в галузі, що діляться своїм досвідом та обговорюють нові засоби у сфері лікування глаукоми. Кожного року тисячі спеціалістів-офтальмологів зустрічаються у рамках численних конференцій, що проводяться за підтримки Thea у різних країнах світу. До них відносяться навчальна конференція Retina, мастер-клас з питань поверхні ока, Європейський клуб спеціалістів з захворювань поверхні ока та глаукоми, та коледж експертів з питань захворювань поверхні ока та глаукоми, хірургічна конференція Thea, а також тур Thea Vision, у рамках якого підкреслюється важливість застосування продуктів, що не містять консервантів. Календар міжнародних подій супроводжується редакторською підтримкою, що є частиною ініціативи Thea з комплектування медичної бібліотеки, яка присвячена різноманітним темам та типам патології, до якої залучено видатних спеціалістів з офтальмології з різних країн, що є ведучими експертами у своїх галузях. Протягом року Thea супроводжує молодих спеціалістів на їх шляху до успіху, а також підтримує визнаних фахівців.
Satellite Symposium by Thea Company. Let's Open Our Eyes is its name. And within the framework of this satellite, we are going to have three reports. The first one is presented by Dr. Professor Druzhina Halina Ivanivna, head of Department of Cornea Pathology. The topic is modern approaches to treatment of neurokeratitis. So, please, Galina Ivanivna, the floor is yours. Dear colleagues, according to modern definition of the President of European Association of Corneal Diseases and Diseases of the Surface of the Eye, the diseases are conditioned by changes of nerves of the cornea, which leads to disorder of sensoric and trophic functions with further impairments of health and integrity of the membranes. If we look at epidemiology, we will see that it's from 5 to 11 cases for 10,000 population, 6% of all herpetic keratitis, a little more herpes zoster keratitis. But if we look at this list of diseases which might cause development of neurotrophic keratopathy, this is hereditary diseases, systemic diseases, impact of systemic preparations which patients take because of other pathology. This is central neural system lesions, Alzheimer's disease, Parkinson's disease, a number of local eye reasons. First of all, viral infections, influence on the surface of the eye of side effect of medications used by patients wearing contact lenses, burns, and practically, if you look, almost all operative surgeries, cataract surgery, keratoplastics, laser procedures, surgery of retina and orbit, which may cause the development of neurotrophic keratopathy. That is why I consider that this disease is determined more often. For today, it is well known that the mutual impact of nerves in cornea and epithelium itself is very important to preserve the integrity of the surface of cornea, because terminal nerves they emanate neuropeptides, and epithelium impacts the growth factors of neural tissue, neural epidermic factor, growth factor. That is why the basic branches of the pathogenesis of neurotrophic keratopathy are impairment of sensitivity and trophic innervation of cornea, decrease of production of tears, decrease of supply of trophic factors, decrease of regenerative potential, and persistent defects of epithelium with threat of perforation. The same authors also offered a new classification of severity level of the neurotrophic keratopathy. It is classified as changes of epithelium without defect of epithelium. So we can clinically see the picture of dry eye, but the patient will have lowered sensitivity of cornea. The medium stage is epithelium defect without defect of stroma, as well as decrease of sensitivity, anesthesia of cornea. The severe stage also concerns stroma, and all patients are diagnosed with neurotrophic keratopathy, because we know that the impact on stroma can really fast cause perforation. Our clinical examples of neurotrophic keratopathy of different etiology may be seen in these photos. Some of the patients have general systemic diseases. What must we know today about diagnostics of this condition? As always, thorough collection of anamnesis, paying attention to any processes inside the skull, like tumors, aneurysms, hemorrhages, somatic diseases, infectious diseases of the anterior chamber of the eye. It is necessary to ask the patient about addictions like alcoholism, drugs, which also decrease the sensitivity of cornea. This includes taking medications, both systemic and local, surgical treatments performed on the eye, and central neural system, as well as determination of third, sixth, and eighth pair pairs of nerves. We also have to always keep in mind the neurotrophic keratopathy and measure the level of sensitivity. So the algorithm of diagnostics include, first of all, the suspect of the disease. Then we try to measure the sensitivity. If it is normal, then this condition, neurotrophic keratopathy, is not probable. If the sensitivity is pathological, then we have to evaluate the stage of the condition. Speaking about diagnostics and sensitivity estimation, it can be quantitative or qualitative. For example, we take a cotton stick and start checking the sensitivity from the healthy eye, and then proceed with the diseased eye. We perform differential diagnostics using different equipment. We try to exclude immune diseases as well as infectious diseases. If we look at the process of treatment of neurotrophic keratopathy, we see that mostly we use preparations like artificial tears, anti-inflammatory, immune correcting, symptomatic preparations helping to regenerate the cornea. We use surgical methods as well, aiming always to prevent the destruction of stroma. We concentrate on the treatment at once and really thoroughly follow up, supervise the development of destruction of stroma. The treatment takes place stage by stage. We use installations, we cancel all the drops that contain conservants or phosphates. We use artificial tears, we use non-steroid anti-inflammatory drops, and necessarily any diseases of eyelids are treated together with neurotrophic neuropathy. Basic preparations used to treat this condition are artificial tears. The first choice preparation is Telos Duo that contains 3% triglyceride and hyaluronic acid, and actually it impacts all the all the aspects of the dry eye. It has a really safe risk buffer, which in complex with the bioprotector triglyceride increases the metabolic activity in the epithelium. The second stage is use of soft contact lens, water serum of blood, doxycycline per os. Also, lateral bletherography may be used temporarily or long term. We can also perform transplantation of amniotic membrane. The third stage should be treated with 90% blepharopathy, transplantation of amniotic membrane, covering of conjunctiva in threatening situations, as a rule in combination with blepharopathy. At all the stages, we use artificial tears and choose triglyceride with hyaluronic acid because it is more significantly providing thickening of the tear coverage even in dry eye disease of moderate stage on the surface of the eye over 4 hours. As it is an inflammatory disease of the surface of the eye on the cornea, it is really important to us that this preparation is not only moisturizing and providing for biological protection, but also it decreases the concentration of inflammatory cytokines and lowering the inflammatory markers, contributing to regeneration of cells. This preparation is practically always used by us in complex treatment of our patients treated conservatively and surgically after keratoplasty. And what is also highly important is that triglyceride with hyaluronic acid provide for faster restoration of epithelium and neural tissues in cornea. We have conducted some experiments which showed that this combination of these substances equals in effectiveness in some cases to installations of water serum of blood. What else is used in our complex treatment? Probably you all have heard about RARH-NGF, which is already in the clinics. It's Oxervate or Senagermin. It can be purchased in Europe already, but it is indeed expensive. Besides, we used installations of insulin used since the beginning of 1990s, initiated by vitreoretinal surgery and platelet-rich plasma to containing a number of growth factors and bioactive proteins providing for regeneration of tissues. Speaking about insulin in treatment of neurotrophic neuropathy, For the recent 2 or 3 decades, we have observed increase of interest to its use, and there has been a number of papers published about it. It was partially conditioned to the number of diabetes surgeries with vitrectomy that could cause keratopathy in cornea. So some receptors were discovered which are similar to growth factors of different types, and it was shown that these receptors are of key importance to keep the integrity of cornea. The clinical practice has literature, scientific data of use of insulin in different concentration from zero point 0.5 to 100 international units. So the majority of authors prefer from 25 to 100 international units per milliliter. In the human insulin is used in our practice as well. Surgical measures, which I have not mentioned yet, it's partial or full blepharopathy, coverage of conjunctiva, keratoplasty, tectonic or penetrative or layer by layer one, neurotization of cornea, aiming at provision of re-innovation of cornea. This direction has been developing since 2009. It was used in combination of lesions of facial nerves. There are different methodologies of it used by neurosurgeons, and for today there have been several experimental research aiming at improvement of integrity of cornea. When neural tissues already appeared after 6 months and grew significantly by 12 months post-operatively. Transplantation of amniotic membrane is a really important method used by us since 2014. Annually, we perform over 50 transplantations, 76% of which are due to neurotrophic keratopathy of different etiology. We have neuropathic ulcers, and in this case combined complex treatment is used. Blepharopathy together with keratoplasty is usually combined in order to increase the life quality of patients. Here are two untypical clinical cases. These are patients who obtained pretty many surgical treatments. A patient of 40 years old who was referred to our department with such neurotrophic persisting defect of epithelium of the transplant. From his anamnesis, we understood that he had piercing trauma with loss of membranes during his garden works, and at his residence location, he had primary surgical treatment, but he was referred to us with secondary detachment of retina, where he got transciliary keratomy with prosthetic in our post-trauma department. He got installation with antiseptic, antioxidants 6 times per day, insulin 6 times per day, dexpanthenol streptocid, eye ointment, Azarga. All the list of preparations might be seen on the slide. 3 weeks post-operatively, the defect of the epithelium of transplant decreased. The edema in stroma persisted though, so the patient continued having hyaluronic acid. 2 months after the surgery, his surface was epithelialized. Vascularization was moderate, but there was residual edema of stroma transplant. His visual acuity was 0.02. He got recommendations, which might be seen in the slide. Another patient of 65 years old with opaque cornea, idiopathic panuveitis and secondary glaucoma in condition after endotrabeculectomy, closed vitrectomy, and you can see almost 4 years since 2019 the number of surgeries which were performed because of his basic condition. For the recent 2 years, he had persisting epithelium defect, not healing, irritation of the surface, light sensitivity, injection of conjunctiva. The patient was consulted in our Department of Inflammatory Diseases of the Eye. You can see the analysis, the tests which were performed. The diagnosis was medium uveitis, autoimmune, cyst, edema, steroid, secondary glaucoma, condition after vitrectomy, neurotrophic keratopathy. He was also prescribed with antiseptic, antioxidants, solutions, 5% natrium chlorine, trigalosa with hyaluronic acid, and systemic treatment as prescribed for the general condition of the main disease of the retina. 2 weeks postoperatively, his condition was improved, the injection was lowered, the defect of the epithelium was decreased. Azarga was substituted with another preparation. 2 months post-operatively, the patient had improvement in cornea. The patient did not wear contact lenses. He took the prescribed preparations and he is still getting systemic therapy and local complex of trigalosa with hyaluronic acid, dexpantanol. For more month, he got installations with insulin, and we are really satisfied that the edema decreased and visual acuity in the left eye increased up to 0.1. Why do we like this preparation so much? Tialose Duo, not only because it has high level of safety, almost never we found complaints of allergic reactions or discomfort, but also this preparation may be used while wearing contact lenses since childhood. It can be used by women in pregnancy and lactation periods. What I would like to add is that when our patient overcame many surgeries in their eyes, like you saw from my example, which I showed you in the beginning of the lecture. Each surgery can be a factor for neurotrophic keropathy, so you never should forget about this risk. And you have to check for light sensitivity in any way you can. And you should always keep in mind the use of artificial tears preparations, like this preparation which is preferred by us. Trigalosa with hyaluronic acid. Thank you for your attention.
Thank you very much. It was very interesting report. We have now time for discussion. Let's present our next speaker, Professor Ульянова Nadia Anatolievna, with a report, cataract analysis of rare clinical cases. Good day, dear colleagues. Taking into consideration our time, we will move further. Of course, cataract is out of norms, and it's the most performed surgery in every ophthalmological hospital. But of course, sometimes you can be in the situation with this boat. You won't know the outcome. Of course, you can see the water flow and the fire burning and the professional performance of cataract. And because cataract surgery is developing very quickly, when surgeon has no obstacles, capsular access without any stops or fragments are removed without problems. Cortical masses lens is implanted, is grafted, and all are happy. But unfortunately, we have different scenarios. Why do we have difficulties? These difficulties uh, can be divided into foreseen and unforeseen, and sometimes they can change their places, and they can cause complications. What prevent? What are the pitfalls of surgeons? Opaque cornea and caused by keratitis and together with neurotrophic keratitis, previously performed surgeries, then injuries. Then, even if cornea is transparent, lack of metastasis is also a pitfall for surgery. Then the weakness of ligaments and other. What difficulties can we have? The rupture of posterior capsule, practically 50% if we have the rupture of this capsule. Even if it is not expanded and it is localized, we should remember that vitreal body prolapse will increase the development of vitreolitis, and will increase the risk of retina detachment. Another one pitfall is floppy iris, syndrome of non-strong iris. Then we will study it step by step. Lack of visualization. How can we help to ourselves during the surgery? In this case, in our trauma department, we use the of cornea is the easiest way. We peel epithelium and cover with viscoelastics, and then under the lens we increase highlight this red reflex. So this lightening of lens, posterior cavity, uh, we can have better visualization. We can use it targetly and on the lateral side, we can see the patient with keratitis, vascularization, and after the lightening behind the lens, uh, there was no necessary visualization. So you can use the target lightening, and it will increase the possibility to see the capsular axis. Once again, cornea can be the pitfall for phacosurgeon, but its absence also doesn't help. Very often we have cases when we have to extract cataract, and the surgery on the open with the open chamber is a challenge. We may have problems with the capsular axis, so we should begin it centralized and then move laterally. There is also a risk of hematology. We should be prepared thoroughly and be prepared for possible complications. And in order to move this nuclear, when our space is open, we should remember about the power of cornea and their dimensions. We see all the dimensions are bigger. IFIS syndrome, so called, it is easily diagnosed intraoperatively when you penetrate by phaco or nail phaco eagle to the iris, and when you have edema and when you have a heel, it's the sign of IFIS. There is a great risk of iris prolapse, not only in form of tunnel but paracensis. And the most unpleasant moment during the operations that pupil is narrowed very quickly. Risk groups are patients with a systematic treatment of blockade medications, patients with prostatitis diseases. So when you have a previous consultation, when you make a pre-examination, it is necessary to ask about the systemic therapy. And also pseudocapsular syndrome is one of the peculiarities and peculiarities of this surgery. What should be the strategy? There are several strategies here. Of course, here you can see the combination of subtenon, lidocaine, and in other prescribed medicines is highly used. We used iris retractors, but there is a technique of microsphincterotomia. It is also usable, but the philosophy of our surgeons won't allow our surgeon to injure iris more. Super strong cataracts are always unnormal because previously our professors, our scientists, they made big incisions and then they began to use small incisions and they use scleral incisions. But for the surgeons of new generation who work with a closed camera, closed chamber, it is a challenge to perform this intercapsular penetration. In this clinical case, I can say that the nucleus of this patient was underestimated, but we tried. We began as phacoemulsification, but taking into consideration maximal parameters, we will damage the cornea. We take a decision uh, to put away, mechanically put away the nuclear. You can see this corneoscleral incision. It's our floppy iris, you can see it. And after the removal of nuclear and cortical masses, you can see posterior chamber without damages, and we used three-component lens with a fixation. And then you can see we repair the iris and finish our surgery. Also about difficulties of cataract surgery. For example, if phaco surgeon has to do primary capsulorhexis, it is necessary to be ready for it, especially when we have posterior polar cataracts. They are inborn cataracts, and these opaques are intensive, and despite the polarization you can see that they are opaque. There is a shadow, and this challenge issue can be resolved in postoperative period with the help of laser, but in this case we took a decision after the grafting of IOL to install viscoelastics between posterior chamber and IOL and to perform posterior capsulorhexis. You can see that this flap is removed easily, and we have transparent posterior capsule. There are some changes to make our to put our eye in a proper location. And when we are sure that there is no prolapse, so we may perform hydroadaptation. When we have intervention of iris into cornea, we perform transallar approach, and here you can see all the process. We implant the lenses fixed to sclera on 3 and 9 hours standard technique. Take it into consideration that this report is within Satellite Symposium of Thea Company. I want to highlight several medicines, namely eye drops that are used for correction of eye surface condition, well-known preparation, artificial tear, that due to the all relevant recommendations is used in patients for correction of dry eye disease. And the company that holds Satellite right now have all necessary preparation medications in his disposal, and there are facial tissues, hygienic tissues, and antibiotics for short courses with a high efficacy. Patients with a preoperative dry eye disease using Telus Duo make better their conditions for grafting IOL. There were studies that patients with eye dry disease have increasement if we are talking about toric lenses with the use of Telos Duo and without Telos Duo. Um, if a patient use Telos Duo, the time of tear film detachment and disruption reduces, and of course it will be the change in our studies. And patients with blepharitis, we are talking about patients with cataracts, diabetes mellitus. It is necessary to eradicate pathogenic microflora because these microflora of eyelids can cause difficulties and complications of the main diseases. We have the results, proven results, that this infection was simple, but it caused very serious difficulties and complications. Their preparations are highly described, and you can use it. So there is a scheme: azithromycin, 1 drop once in 3 days. It helps to prevent the development of gram-positive and gram-negative microorganisms, and it is without conservatives. I want to add that in comparative study in patients that use artificial tears without trigalosis, their results were worse than patients that use artificial tear with triagalosis, because it also influences on epithelialization of nerve fibrosis of cornea. Tylosis duo decrease the manifestations of postoperative inflammation, and of course it's a great advantage of this preparation. That's why we prescribe it in our postoperative scheme. I don't want to repeat one more time, but complex approach together with the surgery and treatment, adequate conservative treatment, is the way to reach success. In conclusion, I want to tell you that abnormal cataract needs non-standard decisions. You can see here the fall of nuclear, and after the implantation of IOL, we have here aphakic eyes, artiphagic eyes. The, this lens was installed in its natural place in the capsule, and there were opportunities to do it. We performed ultrasound phakification, and these joint techniques of several fields help us to reach the best result. Thank you for your attention. Thank you very much.
The next report, Umanets Mykola Mykolaievich, Professor, Doctor of Medical Sciences, Diabetic Retinopathy. Is there a light in the end of the tunnel? Good day, dear colleagues. First of all, I'm glad to greet everyone here, dear Presidium, dear friends, our Satellite Symposium, and my report is about opportunities about proliferative diabetic retinopathy. I will not talk too much about topicality of the topic, because we're amidst pandemic. But the numbers are impressive. 500,000 of newly registered patients have been in 2022, and about the same we've had in 2023. The problem is that half of these patients are living without diagnosed diabetes, and many of these patients have lower hemoglobin, and they are decompensated by the moment when they are diagnosed. They have neuropathy in 26% cases, retinopathy in 17% cases, nephropathy in 7% cases, and so on. So we are looking at the fundus in a very thorough way to diagnose diabetic retinopathy, which threatens with neovascularization, with formation of films and formation of tractions, this which cause detachment of retina, and in some cases we cannot help even with surgery. So about this picture is what we saw 20 years ago. Many surgeons would just give up and not be able to help. But for today, for the present, the situation has changed a lot. By use of modern treatment methods, we easily resolve such complicated problem, which you can see in the video. This happened due to equipment of tools, equipment. We are using bimanual technique. We are using peeling of the internal border membrane. We are using panretinal coagulation. We also prescribe vitamin antioxidant complexes, which aids us. But anyway, there's still the problem of hemostasis despite our steps forward. What are we doing now in order to decrease the number of hemorrhage in the operating theater and outside it? One of my colleagues mentioned that aflibercept administration 3 or 5 days before vitrectomy allows to decrease the risk 3 or 5 times. Some systems of control of the pressure also helps us, and we use electric diathermal coagulation. Despite all our achievements, 75% of risk of hemorrhage is still there. One of our un, one of our questionable methods is temporary tamponade, which can affect the number of hemorrhagic complications. This has been proven by Dmitro Vasilyevich Murik, medical doctor who published his work on this topic. How do PEF2 organic solutions work? They are indeed transparent, they are chemically and metabolically inert, they have low viscosity. A little about the history. First attempts of use of these medications were made in the 60s in 1960s. First of all, they were used as plasma substitutes, and in 1982 Haidt with his co-authors reported about their experience of intravitreal administration of the substance. Perfton octan and perftodecalin, which is a little heavier than the first one, are used. So the goal is to assess the effectiveness of vitrectomy with the use of the substances. We had 12 patients with 12 eyes of first or second type of diabetes. We had 5 eyes with detachment of retina and partial hemophthalm. We used anti-VEGF preparations 3 or 5 days before surgeries. We used perfume organic substance tamponade, which was temporary. We made revision and used silicone or gas tamponades. This table shows the data on our patients. 2 months post-operatively, we also evaluated functional results, anatomical results, and residual manifestations. Every case allowed us to remove the membrane in full, in 100%. We also had 3 cases of hemorrhage. We used perf or octan in one case. The longitude of temporary tamponade was 5 days. And speaking about peculiarities, we had periretinal hemorrhage in one eye, we had ophthalmic hypertension in 3 eyes, we had full attachment of retina in 11 eyes. In one case, we had partial detachment of retina, which lasted. Also, have a look at the picture. These are the cells of epithelium, as we think seen in the posterior part of the lens. And this will be the question for the discussion because we haven't managed to explain their origin. This table also shows the data on our patients, the data of usage of various tamponades, the visual acuity in patients. A couple of clinical cases will be demonstrated here. Here's the tractional detachment of retina. We are removing the film. It is being removed without complications or tears. We notice significant hemorrhage and significant deformation of retina. We administer Decalin, and 5 days after there's revision, we are removing the residual periretinal hemorrhage and finish it with silicone oil tamponade. Another case was total detachment of retina, diabetes. The case is really severe. We managed to remove the film and we are working by probe because modern constructions of vitrectomes allow us to remove a considerable amount of tissues by one tool. In this case, there was inflammatory effect provided. So here you can see these coin changes in the posterior area of the lens, which will have to be explained later. Additional laser and silicone oil tamponade. This is the dynamics 1 week post-operatively. The retina looks normally, and petechial hemorrhages were formed, but they were non-significant. 3 months post-operatively, the condition was stabilized. And the last case was one eye, a girl, first type diabetes. We are performing the operation as the last resort, because as a rule we refuse from such kind of treatment. Surely after removing of the film very quickly, like the surgery lasted about an hour, which is quite long for diabetic retinopathy. So now the retina looks like retina should. Unfortunately, we could not do anything with blood circulation. What can I say about post-operative period is that use of preparations with the IA formula is effective. How can this formula of AREDS help? It contains vitamin D3, acids, a very special attention of these preparations should be paid for treatment of patients with the anti-VEGF effect. Besides, resveratrol in in long-term use can contribute to treatment of the condition and avoid proliferative conditions. Besides, an interesting research was performed by Thea company about patients with anti-VEGF therapy, and it was proven that patients who took Risvaga had better anatomical thickness of retina, and this group required fewer intravitreal injections. So Risvaga in complex with anti-VEGF therapy in patients with macular edema shows good effect. Here you can see the advantages of this molecule helping in the post-operative period. Low dosage Risvaga provides for better micro circulation and prevents neovascularization, supporting hematoretinal barrier. To conclude, our temporary tamponade of Perftor organic substances supports us in quite severe cases. As our research showed, we had less problems with these substances, with these medications. In all the cases that we researched, tractional deformation of retina was removed. So the usage of Perftor can only be can only take place in the inpatient treatment. By no means one should use it at home. So the physician has to focus on this point. In post-operative period, the use of Nutrof and Risvaga are able to help us and support our patients. Thank you very much for your attention. Thank you, Mykola Mykolaievich. We are finishing the Satellite Symposium. We would like to say thank you to all the speakers, Mykola Mykolaievich, Nadia Anatolievna, Galina Ivanivna. Also, we would express gratitude to Thea company for their support. So please come to us, join us. We would like to present you a small certificate of gratitude. Thank you for your friendship for many years. We are doing it together. Thank you.
Thea – це незалежна європейська група номер 1 у галузі офтальмології. Це глобальна група, що має розгалужену структуру, яка постійно поширюється та становить вже більше 35 філій. Комерціалізація продуктів групи поширюється вже більш ніж на 75 країн світу. Комерційний оборот Thea становить більш ніж 865 мільйонів євро. Компанія Thea має далекий горизонт стратегічного бачення. Для неї властиві швидке реагування та надійні системи незалежних лабораторій, що займаються виключно вивченням питань офтальмології. Засновники та директори компанії Анрі та Жан-Фредерік Шибре належать до генерації засновників цієї галузі. Thea щільно пов'язана із десятками тисяч спеціалістів-офтальмологів з різних країн, які довіряють нам та яких ми підтримуємо протягом довгого часу, особливо в сферах удосконалення та обміну знаннями. Thea має значний експертний досвід у багатьох галузях, а саме в розробці інноваційних продуктів різних класів, а також досягає успіхів у лікуванні глаукоми, алергії, інфекційних уражень, запалення, хвороби сухого ока. За допомогою Thea було створено нові концепції та нові ринки для продуктів, що не містять консервантів, продуктів для підтримки зору, для гігієни повік, антибіотиків для внутрішньокамерного введення та мідріатиків. Основою вибору найкращих виробників для кожної фармацевтичної форми є зберігання компанією певних стратегічних технологій. Маркетингові технології компанії створено в комбінації з однією з найбільших систем медичних та фармацевтичних контактів у сфері офтальмології. Відділ розробки має визнаний експертний досвід у створенні фармацевтичних форм, розробці продуктів та проведенні як доклінічних, так і клінічних досліджень, а також у сферах реєстрації продуктів та виводу їх на ринок. Thea Open Innovation – споріднена організація компанії Thea, що займається створенням партнерств та підтриманням стартапів, співпрацює з компаніями з розробки медичних та біологічних технологій та з університетами з різних країн світу для створення інноваційних технологій та методів лікування майбутнього. Thea – унікальний партнер у сфері офтальмології.
У світі, де науковий прогрес змінює наші можливості кожного дня, компанія Thea допомагає спеціалістам-офтальмологам, як тим, що тільки починають навчання, так і досвідченим фахівцям, що потребують регулярних тренувань для підтримання професійних навичок. Thea супроводжує спеціалістів-офтальмологів до їх майбутнього за допомогою Академії Thea, що централізує різноманітні активності, присвячені молодим фахівцям. Для підтримки ініціатив, що їх було створено молодими спеціалістами задля молодих спеціалістах, у рамках конференцій EMYO та окремих сесій, що проводилися під час конгресів за участю ведучих офтальмологічних спілок. Для хірургів, що тільки починають практику, чи тих, що хочуть вдосконалити свою техніку, є можливість працювати на симуляторах Dry Lab та Wet Lab або на хірургічних симуляторах. Ми запрошуємо резидентів та лідерів клінічної галузі для участі у Trophy, нашому міжнародному змаганню із презентацією клінічних випадків, що надає лауреатам можливість презентувати свій клінічний досвід у рамках відомих конгресів. Більш ніж 1000 учасників вже спробували свою вдачу. Також ми надаємо інституційну допомогу Європейському комітету з офтальмології, що надає молодим практикам можливість працювати у Європі. Динаміка обміну знаннями та їх розповсюдження не обмежується колом молодих спеціалістів, але стосується усіх практикуючих фахівців, як тих, що тільки починають працювати, так і визнаних спеціалістів. Глобальна ініціатива безперервного навчання відображується у проведенні численних заходів, що їх присвячено різним видам патології. Thea підтримує престижні заходи, наприклад, міжнародний симпозіум з глаукоми Мурфілд, що надає унікальну та рідкісну можливість вдосконалення, тому що цей симпозіум відвідують найкращі фахівці в галузі, що діляться своїм досвідом та обговорюють нові засоби у сфері лікування глаукоми. Кожного року тисячі спеціалістів-офтальмологів зустрічаються у рамках численних конференцій, що проводяться за підтримки Thea у різних країнах світу. До них відносяться навчальна конференція Рітіна, мастер-клас з питань поверхні ока, Європейський клуб спеціалістів з захворювань поверхні ока та глаукоми та коледж експертів з питань захворювань поверхні ока та глаукоми, хірургічна конференція Thea, а також тур Thea Vision, у рамках якого підкреслює